have the right sequence of progression of infection prevention control at a facility level, the role of the leadership at a facility level, and we have witnessed what can be achieved at a sub-national level in terms of the political action plan for controlling infections in general and controlling antimicrobial resistance in particular. I think Kerala has been the model for most of the initiatives in the country. Not only the country, Kerala is a model for a lot of other countries as well, even though it is a small state. Looking from that angle, unless the antimicrobial resistance is thought through a systems lens, all of us understand the burden of antimicrobial resistance. We also understand the rate of growth of antimicrobial resistance, that it is a real threat, slow threat, but a real threat. There also have been action plans, the global action plans, national action plans, state action plans. But however, we are not witnessing in the growth rate that is supposed to get flattened. We are not witnessing the change that is expected of antimicrobial resistance. The reason is that for too long, the focus was only on antibiotic stewardship in the hospitals, assuming that entire cause of antimicrobial resistance is only in the hospitals, and that is where the action need to be addressed. But if we look at from the systems lens, the upstream determinants which are leading to this antimicrobial resistance in the community and in the healthcare provider systems. The one is, what is the exposure of the microbes to the antimicrobes? Can we act at that level? It is the human usage, animal usage, the plant usage, and the drainage from the manufacturing units into the environment, and the drainage from the users themselves when they dispose antibiotics into the environment. It is not just at one point. It is at multiple points, the exposure of the microbes to the antimicrobial, because that sets the stage for the antimicrobial resistance. The next level is the exposure of people to the microbes which have the resistance. So that is the next level of prevention, that are we able to prevent the infection at the transmission to the human beings? And the third level is, are we detecting in the right time and initiating appropriate treatment at the right time? I think these are the three levels of interventions looking from the systems angle. We have a great panelist because as Madam has mentioned, it has to be a multi-stakeholder, a cohesive and collaborative action through a systems thinking. If we really want to achieve the antimicrobial resistance control, in particular, of course, infection prevention in general. Looking from the 30,000 feet angle, that is the global lens, what exactly are the global actions in this direction of antimicrobial resistance? Since we have the representative from the India office of the CDC, CDC, though it is a US national CDC, but it has a significant global role across the world and across the countries. From a global perspective, in terms of the action, we are listening to the IHR amendments, we are listening to the pandemic treaty, we are listening to the pandemic fund, and also we are looking at the WTO talking about how to make equitable access to the innovations, that is essential innovations in terms of diagnostics, in terms of the vaccines, in terms of the drugs. So what are the actions that are happening from the global perspective? Daniel, over to you. Yeah, it's working.
Yes, thank you. So I think from the global perspective, I think one, we have to really appreciate that people are coming together. And this was pointed out in the UN General Assembly, where you had leaders come together to make commitments, to sign on to political declaration with specific targets to reduce AMR deaths by 10% by 2030. I think you also have to appreciate that they're willing to commit funds. And I think this came up in one of the last sessions, is like funding matters. You can't do this without resources and commitment that as far as funding national action plans, 60% of countries will fund it by 2030, which is a big deal. I think the other thing that we have to really appreciate as far as being encouraged in this space is that there are systems in place for sharing of data. You have systems that WHO has put together for both the human, animal, agricultural side, where we can then look. These are imperfect systems. They don't have all of the data, but they're at least a start on an international space. And these would have to be recreated at a state level, at a national level. So this is also the challenge for countries. I think thirdly, there's accountability. There's a system where every country is reporting back on their AMR progress, and that's being tracked. And notably, as presented in the General Assembly, there's gaps, and we aren't there yet. But rather than being punitive and saying somebody's not doing a good job, we see this as an opportunity to say, this is where we have the opportunity to lean in, both with governments supplying funds, but also with interested parties, private companies, individuals, philanthropic organizations, and consortiums. So I think all those are very important.
Thank you, Daniel. I think one of the point from global perspective is the responsibility of each person, right from the lab to the state level and to the countries, how they're actually sharing the data in terms of the antimicrobial resistance and other things. So that is, I think, as a part of the international health regulation, need not be a regulation if it is a self-regulation and people are reporting whatever is the reportable data for taking immediate alerts. I think that is one of the important action point that comes out of the global international health regulation, which applies to the national health regulation. Unfortunately, in the country, we don't have the mandate to everyone, not just the public health providers, but private health providers as well, to report the microbial picture. So that's one of the things a key takeaway from this comment in terms of the global perspective. I have some more questions going forward. I come to Dr. Kamini Walia in terms of assessing from a systems perspective at a national level, because unless we know where we are in terms of what is the extent of the contamination, the antibiotic usage in the animal space, in the plant space, what is the contamination on account of the effluents into the environment by the antibiotics. So that is one level of that. And fortunately, I think in the morning discussion in terms of the environmental surveillance might give us some extent of idea of how actually the resistance is growing. But in terms of the response of the healthcare system, is it really responding in terms of the IPC protocols, in terms of the mandate for quality assurance by these providers? So as a Department of Health Research, since ICMR is part of the Department of Health Research, are there any system level assessments at a country level or at a state level with reference to the AMR in particular, but infections in general?
Thank you. So AMR, as we see in our country, is not just a medical issue. It has its roots in our social, economic, and regulatory landscape. And we have to understand the problem, only then we can really devise solutions. So ICMR's research program on antimicrobial resistance is actually focusing on that. Regarding the systems approach, when we started working in this space 10 years back, we put together one of the first national networks on antimicrobial resistance. There are two networks which are functional now. One is by the Indian Council of Medical Research and the other is by the National Center for Disease Control. I wouldn't say that these networks are representative of the entire country or entire healthcare system, because we are a very big country and we are only able to present a fraction of data from tertiary care hospitals. But then the constraints are the absence of laboratories in all levels of healthcare. That is why there was a question in the morning when one of the panel's chair asked how many hospitals have antibiogram. That is the challenge that we face, and that actually is holding us back from having a national footprint of the AMR problem. But I think efforts are going in the right direction. ICMR's and NCDC's efforts, which are now limited to tertiary care hospitals, there is now a plan to expand them to the secondary level hospital. The IPC, the antimicrobial stewardship, everything right now is limited to a few tertiary care hospitals. But as we heard in the morning, now the NABH is actually rolling out a program for Arogya Mandirs, which is like a primary healthcare center or a wellness centers. So those are the kind of guidance documents we were initially we were missing them. But now, as there is more and more awareness at the part of the government, there is a commitment to improve availability of healthcare services at all levels. So I see that the program is aspirational, and sure we will be able to bring out a more comprehensive and a more holistic picture of the antimicrobial resistance disease burden in the country. Regarding the discussion around contribution of environment and how does the animal livestock antimicrobial use actually contribute to the human or a clinical dimension of AMR, I would say there is still a lot of unknowns in that area, which we still do not understand. How much of the clinical or human dimension of AMR that we see in the hospitals is attributable by environment or is attributable by the livestock or the fishery or the agriculture use of antimicrobial. But now the Indian Council of Agriculture Research has put together a network, and since last year they are also bringing out their report on the extent of AMR that they see in the animals or the fisheries sector. So I think all these steps are they augur well with our intention of having a more holistic and a more systematic systems approach, because unless we have the evidence, we cannot really devise evidence-based interventions. Regarding IPC, antimicrobial stewardship, availability of diagnostics, so all these are we are very much aware of these gaps. There is a national guideline on infection prevention and control in the hospitals. There is a ICMR guideline on antimicrobial stewardship. We have had one full task force program on just combing through what is available in India, which we can use as a point of care diagnostic, which can help in pathogen identification and antimicrobial susceptibility. So on the whole, I would say there is a willingness and also understanding that we do not know enough about how antimicrobial resistance is driven in our country, besides the fact that there is a very high antimicrobial pressure, and we need to bring down that antimicrobial pressure to strengthen the AMR containment efforts. But then there is a now concerted effort in every direction, and I think next few years will be we will see ourselves making huge progress in that direction.
Yeah, just carrying forward on that in terms of the vital requirement of knowing the actual burden, especially coming from the animal sector and the environment and other things. Catching on to the morning session in terms of the environmental surveillance, given the COVID experience and also the power of genomic surveillance and environmental surveillance and even the big data surveillance, what is the appetite from the policy making to integrate some of these innovative disruptive surveillance techniques into the routine surveillance systems?
As I said, we do not know the exact contribution of these antibiotic use, how they prevail in the environment, and what is their role. The wastewater surveillance, there was a complete panel in the morning, they were discussing how it was useful in viral infections and trying to find out what is the chronology of appearance of virus in the sewage and followed by the human infection. This we know worked very well for polio. The entire polio program actually was hinging upon our sewage surveillance, and that actually led to identification of the hotspots and containment efforts quick. Unfortunately, that kind of evidence is still eluding us as far as antimicrobial resistance is concerned. We found MCR1, MCR2 for colistin resistance many years back in the environment. We have still not come across the clinical isolates which express MCR1 and MCR2. So but for enteric infections, I would say that is very, very relevant. Enteric infections is something where there is a fecal contamination of the water, and then that subsequently leads to enteric infection. So those are some of the pathogens, but it cannot be, I would say, applied to all the pathogens that we start looking for organisms, pathogens and genes in sewage, and we start looking for, that chronology still needs to be established. Wastewater surveillance or the sewage surveillance will definitely be helpful in understanding transmission, evolution, as well as can we really use them as a proxy for clinical surveillance wherever we are not able to have antibiogram. Yeah. But I think more research needs to be done.
Yeah, Rakesh, I think carrying forward same discussion in terms of the environmental surveillance and its relevance to the clinical application. We have noticed actually that you were picking up the spikes, but there was no clinical correlation. So that means the environmental burden versus the clinical burden. Suppose I have a robust infection prevention systems, the environmental burden may not translate into the clinical burden. So this is where I think there is a need for additional research. Is TICS or this alliance is pursuing that research, because for the policymakers to make it as an integral part of a clinical surveillance, some of these unanswered questions might have to be answered. How it translates into actionable insight in preventing a clinical endemicity or epidemic. Rakesh, over.
So, Dr. Walia mentioned, it's very difficult to correlate what we see in environment and time with the clinical eye. So, one thing what has been missed, the environmental surveillance has not been very extensive, and to correlate what is there in the hospitals and in the wastewater, then we have to look at the STP of the hospital, which I'm not sure if it has been done extensively. What waste surveillance we have done and seen plenty of scary picture of AMR is from general STPs of the people, which has also animal contributions, poultry contributions, everything is coming. And it is true, like you mentioned, most of time we see the MRGs that are for antibiotic which we are not using for the. So that means it is coming from the environment. The danger is that the bacteria, they are very powerful. And they have evolved, and they are actually a very large number, and number is their strength. So they are all in the time, and they also have various mechanisms like lateral transfer, which means a bacteria getting resistance from something else can transfer to something else, which can come. So we are so much connected. I mean, One Health is the whole concept of this kind. So I think by doing consistently over a period of time for, let's say, a couple of years at least, the wastewater surveillance from STP from the clinical setting, and then matching with what we are seeing in the clinic or that hospital will help us a lot. And like also Dr. Walia mentioned, we must understand how the AMR emerges. What is the evolutionary forces that are there working as a selection pressure? So, which is antibiotic, of course, but from which route it is coming and every drug has its lifetime. If it is against a bacteria, they will develop resistance one day or other. But I think we have been a little bit careless. So now if we get surveillance done carefully and see the pattern there and see how it changes with the time, and we can have a strategy of usage of antibiotic, what we have right now. Of course, there's another thing that we have to have more options to fight this disease. I think we can delay resistance for many one of them, and therefore the scientists, the epidemiologists, and the clinicians have to work together. I think there are ways of handling this, and lots of awareness have come about this in general public also after the COVID, and after now the clear-cut evidence that emerging about the AMR. So AMR literacy is going to be important. I think multiple ways if we approach, surveillance will become more effective and contributes help.
Yes, since Rakesh, I mean, I just carry forward into the next level. Like when we contract the infection, I mean, in terms of getting the system ready, ecosystem ready in the country, in developing a rapid diagnostic test and also a rapid vaccine or a rapid treatment. In terms of the ecosystem, I mean, the government R&D institute, you are part of the government R&D institute. Now you are part of a non-government, non-profit R&D institute, and you also interact with for-profit R&D institutes. What is your perspective in terms? Because one of the things that we notice is lack of access to a rapid diagnosis leads to inappropriate empiric antibiotic usage, right, from in the clinics or anywhere. So that can be one solution to prevent that inappropriate antibiotic usage. If you have a rapid diagnostic to say, is it a viral infection? Is it a bacterial infection? If it is a bacterial infection, can we rapidly tell which bacteria it is? And with the genomics, sometimes with the miniaturization of PCR, you may be able to tell whether there is any resistance also with the ADRs that you mentioned in the morning. So since you have been actually spearheading some of this ecosystem development for creating a rapid approach at the country level of developing a diagnostic test or developing a drug or repurposing a drug. What is your take on that?
I think that is the really happening field. And I'm sure in coming few months or a year, we will see the results of the effort that is happening in many different places about the diagnostic, and maybe a little bit improved response also in terms of. So diagnostic, now we have seen for the COVID, we could do in hours. So why not for AMR? So we have to look for the diagnostic, which is not based on microbiology technique, because that requires the growth of bacteria, so you need certain time. So DNA based diagnostics will be very, very helpful, and lots of companies and organizations, including ours, are working on rapid diagnostics of first to find, like as you very rightly mentioned, first find out whether it's fungal or viral or bacteria. This should be simple to do. In parallel, we can also set up, now these things are becoming affordable, they are becoming indigenous, and the diagnostics, one thing that has thrived as an industry also during the COVID, which is very good thing, that most of time clinicians are forced to take a decision without really knowing what it is. If you're not diagnosed, they are taking based on what experience they have. That doesn't mean that each time the pathogen will be same. So they are also forced to give those treatment. So if we come with the diagnostic which works in 2 hours, 3 hours, then we will be able to. That will be, I think, a game changer. So many of them where this not required will not be given, and at least we can figure out very quickly what are resistance are there. So avoid those, and then take care of the patient much better way with better out. About the treatments, of course, antibiotics is one thing. One way of which we are now discussing and listening from experts from many other places is that when we assay the sensitivity of the antibiotic, we are using microbiology technique. It might be a different result when if you tissue culture technique, which is more mimicking the body. Bacteria will respond to something depending on the environment it is grown. So it will be a good idea to isolate these bugs and test them in human cell conditions and not in petri dish conditions, where the bacteria respond. Bacteria are very flexible and they're very smart, so they respond to environment very. The other aspects of treatment is to have combined treatments, help with immune system trigger, and they use the existing antibiotics. And of course, there is a lot of research happening on completely new kind of antibacterial agents. Lots of research is happening in many places. Even CCMB has come up with the new targets of drugs, where if you put them, bacteria will not able to divide. So those are the things, those kinds of drugs bacteria has not seen. So once we come up with those things, it will take much longer time for bacteria to acquire resistance. And another approach is whether the CRISPR technology or RNA targeting. So then those will be much more advanced kinds of treatment where bacteria will not able to do much, because it will evolve and then we'll know immediately, and next day we can change the, let's say, antisense what we are using. So I think lots of research is happening, and although it is a big problem, but knowing what is the extent, how the bacteria is evolving, knowing its dynamics in the environmental context, linking it to the clinical settings, and then taking new approaches of faster diagnosis, which very much feasible. I can see this happening very soon. And then little bit more kind of supported or combinatorial, or let's say combined approaches for treatment will be helpful. So I'm hopeful that we'll be able to come up with the solution as relatively soon.
Yeah, thanks, Rakesh. I mean, taking forward the same dialogue in terms of what Bharat Biotech represents, it was a clear-cut demonstration how collaboration between the private sector and the public sector and a pre-existing clinical research network, how we can actually fast track some of the development of the vaccine. But in terms of the preparedness for the future, investing into some of the platforms, because private sector alone may not be able to invest into the platforms like mRNA platform or a phase technology platform or an immunotherapeutics platform. Can we actually institutionalize this in terms of a public investment, a philanthropic investment, plus a private investment? Because when there is a pooling of investments, the risk reduction is significant. I mean, the cost of development with this collaboration is 10 times cheaper compared to a single pharmaceutical company actually trying to develop one antimicrobial agent. What are your take on this collaborative approach to the developing and keeping the platforms ready for the future?
Thank you, Dr. Reddy, and thank the organizer for having us here. You mentioned the COVID pandemic and how we partnered. Our colleagues from ICMR are here. It was a very active partnership and very aggressive partnership, I would say. And if traditional product development, it is all based on design of experiments and doing a few experiments, waiting for the results and hypothesizing for the next set of experiments. During COVID, we threw all of that out the window. We did hundreds of experiments in parallel, not knowing what the results are going to be, and we started planning the next 100 experiments irrespective of the results. I think that's the way we were able to move forward. Although governments and NGOs and regulators, everybody were all on the same page in terms of additional resources and human resources, especially to review and give regulatory approvals in good speed. So that's the reason why during COVID we were able to do it in a different speed. I'm not so sure for other targets and other problems whether we could deploy the same kind of resources and muster the same kind of timelines that we did for COVID. That is a matter for discussion. Having said that, we, from a vaccines perspective, are focused on certain vaccines where we see disease burden, where we see a high amount of usage of antibiotics, whether we could deploy those vaccines in certain situations and reduce antibiotic usage and thereby reducing, AMR. We have a case in point with our typhoid conjugate vaccine, which we were the first ones to develop in the world. And we were able to, Pakistan in 2016 had an outbreak of multi-drug resistant Salmonella typhi in our namesake of Hyderabad in Pakistan and Karachi. So we partnered with the Aga Khan University, developed clinical testing protocols, and they deployed it in almost 23,000 subjects. And the results were excellent in the sense that they were able to demonstrate that by using a conjugate vaccine for typhoid, they were able to reduce the disease burden not just in culture positive Salmonella typhus, but also the ones that were multi-drug resistant strains of Salmonella typhi. I think that's an early signal for us. That was almost 5 years ago when we did that study. Now we are working on different types of prophylaxis where maybe when you call it a broad spectrum antibiotic, working on something like a broad spectrum vaccine, which could maybe recognize certain motifs on multiple organisms and attack it, at least as a first line of defense, so that we can see some benefits on that. But that's where we are going towards. But again, from a systems perspective, even though we are in vaccines, we may not be as knowledgeable about public health. But we know that if AMR has to be conquered, it has to be conquered in the field and not just in the hospitals. Thank you.
Thanks, Prasad. I think in short of time, but I have one more question to Dr. Vijay Agarwal. In terms of, since you focus on only few hospitals which are accredited by NABH, it's hardly 5% of healthcare providers in the country. 95% happens in nursing homes, small hospitals, medium hospitals. None of them is accredited. We ask for quality assurance for even a small syringe or a gloves or other things. But why country cannot mandate every provider that they have to assure quality of service as a mandate, not as an option? Why they are not mandated?
So it's a good question, sir. Now let's also understand that what does quality assurance achieve? And when you said that, you also talked about, let's say, quality assurance, whether it is somewhat different in India and other places. So, right. So let's first of all, the whole issue is that we are a very complex system. Country is complex, but let's look at somebody which is less complex like United States. And you find that even after 80 years of quality assurance being in place, the preventable medical errors causing death are the third leading cause of death in that country. So one has to realize one thing, that what you are dealing with is not something simple. And this can be understood if you just try to focus onto the theory of complexity. So when you look at what are the complex things, there can be simple, complicated, complex, or chaotic. Now, majority of the times, people are thinking that as if we are dealing with complicated things. Complicated things have solutions. Complicated things you are able to make up. For example, if I have to diagnose pneumonia, something, with my knowledge, I look at the symptoms, I look at the X-ray, I come out to a diagnosis, and I am creating a solution. Getting an accreditation or a quality assurance also comes under the category of being complicated. So you can achieve the stamp of quality assurance because that's a complicated process. Everybody knows what is the drill, what are the checklists, what is it that I'm supposed to do, and the quality assurance is done. But is it going to create an impact? That requires developing a culture of safety. And developing a culture of safety is another ballgame that comes under the category of being complex. And that is where you need a systems lens, as you started. You need a systems lens to start approaching the problem. And when you look at the systems lens, you are not going to solve this problem by looking at individual components. As a system leader, you have to think of the bigger picture. You have to bring people together. There are many things that we are not talking. There are hundreds and thousands of general practitioners who are lying all across the country who are prescribing medicines. Right from our medical education, what is our emphasis on learning about these things and about medical errors? So I feel that our problem of AMR, the way we are going around at this time, will remain so, because one should understand complex problems can only be managed. They don't have a solution.
Thanks.
And we have to kind of come together to create a strategy.
Thanks, because of, I think, the organizers are looking from behind at me. Sorry for panelists for some more questions that we were to discuss, but we can discuss, I think, over lunch. I just would like to summarize, I think, the importance of the systems approach to the AMR control. The conclusion is not that it has to be done iteratively, multi-stakeholder collaboration, cooperation. It is not by regulation, it is by individual desire and the mission that every patient matters and every safety matters. I think this is what I think a lot of youngsters who actually take care of the patients, who actually influence some of these decisions are in the audience. The take-home message is that this problem is not simple, but at the same time, it is solvable if you address through the systems lens, right from the whole of systems, whole of government, One Health approaches. So with these few comments, I'm afraid we don't have any time for any questions. Thanks for everything. Thank the organizers. Thank you all.